Thank you, and congrats to Sonia and Michael. Before I start, I'd like to take 10 seconds of my talk in memoriam for Joseph Colin, a great teacher, a great innovator, and unfortunately for me, a very good friend for just the last 5 years. So 10 seconds in memoriam for Joseph Colin. Thank you. These are my financial interests and some pleasant financial obligations, and many of them are relevant to the talk I'll be giving you. Unfortunately, Joseph is missing from this picture. Who in here thinks cross-linking is a refractive procedure? Let's see hands. Who thinks collagen cross-linking is a refractive procedure? Okay, I'll try and change that trend. This is a case a little more impressive than what Theo showed us. This is a case of mine from 2003. 10 years later, has flattened 12 diopters. This is just standard Dresden protocol collagen cross-linking. Can we get corneas from this mode on the left to turn almost non-keratoconic to the right? Yes, I've showed this to you many years now. This is performed with collagen, high-fluence collagen cross-linking and topography-guided PRK normalization of the surface. That's the Athens protocol. It started the other way around, cross-linking first, lasering later. But we did, in my opinion, a conclusive study showing that if you combine, you get more of an effect, less scarring, and of course, one procedure instead of two. The Athens protocol is something we have published extensively. You have about 140 citations in your outlines. And of course, when you do this treatment, you have to consider epithelial mapping. And this is done very easily with an OCT, and you can see that this cornea, if you take out the epithelium, will be completely different. Thus, the PRK first, and then PTK, high-fluence collagen cross-linking, and mitomycin C. I know this is not FDA approved yet, but we're able to turn a very unhappy post-ectasia LASIK patient seen here, turn into a 2015 pilot, and this is stable long-term. Now, this comes with a cost. Normalization at some point means that you steepen the central cornea and you may induce myopia. So this is not a refractive procedure combining topography-guided PRK and cross-linking. And you can see here, though, before and after, how all the irregularity indices, and I'd like for you who are looking for keratoconus and looking for progressions to focus more at the asymmetry indices than what we usually do, vision, keratometry, and cornea thickness. We've shown, looking at huge case series over these last 10 years, that although this is a lousy refractive procedure, because uncorrected visual acuity is all over the place, but best spectacle corrected visual acuity is at worst at 20/40, 20/50 for all of these patients. And for a cornea transplant surgeon, this means a lot. I wish all my graphs were 20/40 or 20/50, best spectacle corrected. I'd be a happier person. Of course, this point was made earlier. These eyes tend to flatten as years go by. These are a huge cohort of our patients showing that they show a continuing flattening effect. But cross-linking is very crude at this point, and we'll try and learn why is it that there's refractive changes. There's a cost as well with the Athens protocol, delayed epi-closure. You can get these Saltzman-like nodules. We've reported on this. We have the option of using many different topographies to treat. We published this year that Seinflug-driven have better result than placebo-driven as far as improving the asymmetry indices, and this is, again, a huge cohort of patients. And of course, we improve the anterior cornea surface, but the posterior remains the same. So these eyes have a limit to their visual rehabilitation as far as just shaping up the front surface, cross-linking the cornea, and of course, I'm talking about keratoconic eyes and post-LASIK ectasia eyes. So could we obtain this? This is keratoconus that's improved. Very specifically, about 2.5 diopters improvement from the irregular astigmatism. Now, this is 4-month results from a topography customized transepithelial CXL treatment. This is done with a KXL2 device by Vidro, currently CE marked, and now this is kind of hard to understand. We can customize not only the format of the energy that is placed on the cornea, but give different gradients. As you can see here, this area, the whole area is 5 joules energy. The bow tie, which is the one plan to correct astigmatism, is 12 joules energy at the same setting with a tracker on the cornea transepithelially. It sounds like science fiction. I'm going to go back again. before and after, 4 months later. This patient now is 20/20 from 20/40. I cannot promise you this will hold forever, but this is a remarkable result for me. People thought I was mad when I talked about prophylactic high-fluence CXL and LASIK. Maybe I am. But we showed, and this is conclusively this year, that when you use it in hyperopic LASIK, you get more stable keratometries long-term out. And many of you know that hyperopic LASIK regresses. This is not residual accommodation. This is a continuing flattening of the cornea after we steepen it. So for many years now, we exclusively combine it with post-LASIK in hyperopes. Now, I want to thank Mo Minkler from University of Irvine of giving us these tremendous pictures of nonlinear, optical, microscopic, ex vivo look of corneas. And I'll show you something that to me is very remarkable. This is irrelevant to refractive surgery and inlay keratoprosthesis, the KeraClear. Now, in order to place this in the cornea that had severe disease in the anterior portion, I cross-linked in a 400 micron pocket the underlying cornea seen here, and then cross-linked the surface with a second session of high-fluence cross-linking. Remove the button that you see here, this is a 3mm button, and place the prosthesis as an inlay. Here you can see the anterior hyperreflectivity on collagen autofluorescence, showing the surface cross-linking, we all know that. But you can also see the bottom hyperreflectivity, showing a clinical effect with in-pocket cross-linking, which applies to LASIK as well. We've showed and published this year using high-fluence cross-linking to create these CXL differentials within the cornea to augment astigmatic keratotomy, and again, being able to get a 3-diopter myopic correction with cross-linking alone. This is a topography customized treatment with a KXL2 device. Very impressive, holds for 12 weeks. We'll show you some results next year. This is a device, and I do have financial interest. And here, using it customized through the cornea, BJ Dupes gives us the tips on this. So these are current protocols, and I want to conclude saying that CXL has come beyond a way to stabilize ectasia. It's a modulator for corneal biomechanics. If we customize fluence and topographic application, we may have refractive changes that will change the view of refractive surgery. And I thank you very much for your attention.